Like to introduce you to Dr. Bashar Bukhamsin. Dr. Bukhamsin is a pediatric emergency physician and point of care ultrasound lead at the Winnipeg Children's Hospital for a little over a year. He is an assistant professor in the Department of Pediatrics and Child Health at the University of Manitoba. Dr. Bukhamsin completed his fellowship in pediatric emergency medicine and point of care ultrasound at Sick Kids Hospital in Toronto. And an interesting fact about Dr. Bukhamsin is that he moved from Saudi Arabia to Winnipeg in 2023. Thank you, and over to you, Dr. Bukhamsin.
All right, thank you. All right, so I'm going to be going through ocular emergencies. Some conditions are true emergencies that need immediate reaction, recognition, and treatment. Some not so emergent conditions that you might see in the emergency department, an urgent care clinic, or just the regular clinic that patients might present their children with. So a few of the objectives, we're going to go through ocular assessment, mostly a review of assessing an eye. We'll go through pathologies in pupils, cellulitis of the preorbital and orbital, eyelid abnormalities of the lacrimal system, conjunctivitis, both in children and neonates, some pathologies in the anterior and posterior segments of the eye, and finally, injury and trauma of the eye. So we'll start off with an ocular assessment. So a review of the anatomy of the eye. You have the anterior segment of the eye, which is divided into the anterior chamber and the posterior chamber. And then you have the posterior segment of the eye, which is what's behind the lens. And the vitreous body in the posterior segments is surrounded by the retina. And at the end of the eye, you have the optic nerve going into the back of the eye. So during an assessment, you want to make the patient as comfortable as possible, especially since you're dealing with a child. So you'd want to use an anesthetic eye drops, especially if a patient comes in with an eye trauma, to help relieve the pain and ease your examination. You want to assess the eyelids and the surrounding skin around the eye, the sclera, for any redness or hemorrhage, the shapes of the pupils and their reaction to light, any signs of perforation, any visible foreign bodies, and sometimes you might need to retract the eyelids to be able to see underneath if there's any hidden small foreign bodies. You want to assess the vision, both acuity and the field of vision, the extraocular movements, the red reflex for leukocoria. You'd need to use sometimes fluorescein eye drops to look for any abrasions or dendritic patterns for HSV. A tonometry to assess the intraocular pressure. Now, normal intraocular pressure is between 10 and 20, 10 and 21. And finally, either a fundoscopy or an ultrasound to assess the back of the eye, the papilla, to check the papilla if there's any swelling of the papilla. Now, remember to always be patient when assessing a child. Most children, especially the young one, will be uncooperative. So a good idea would be to start with observation at a distance in those really young children. You can get a lot of information with observation alone, even before touching the child. So for example, use a moving toy to assess the extraocular movement of a child. So start with that to decrease any anxiety the patient might have, and then you can go ahead and start, and then you can lay your hands on the patient and put the drops if you need to. So starting with pupil abnormality, I'm just going to mention this one pupil pathology when you have two different sizes of the pupil. So you see the child has a larger pupil on its right eye compared to the left one. And this is called anisocoria. Now, the thing with anisocoria is trying to figure out which pupil is the abnormal one, which one is either abnormally dilated or abnormally constricted. So you want to examine the patient with the room lights on and off. If you notice that the difference of the pupil sizes is more when the room is dark, then the smaller pupil is abnormal, because normally if the room is dark, both pupils should dilate. And if the difference in size is has increased, then the smaller pupil is not dilated enough or at all. That means the smaller pupil is abnormal. And if then you turn the lights on, and with the room lit, the larger pupil is abnormal, then that tells you, sorry, if the difference is more when the lights are on, that tells you that the larger pupil is abnormal. Because when you turn the lights on, obviously the pupils will constrict. So if the larger pupil is abnormal, it will barely or not constrict at all, and you'll see an increase in the difference of the size of the pupils. So what does it mean if somebody comes in with anisocoria? So there's a few conditions that can cause it. Something called benign essential anisocoria. That is present in about 20% of the population, normally present in 20% of the populations, wouldn't be considered a pathology. And the way to be able to diagnose it is if the difference between the two pupils is less than 2 millimeters. So that would be considered just normal for 20% of the population. Other conditions are cranial nerve 3 palsy, Horner syndrome, iritis, or trauma. So for all other conditions besides benign essential anisocoria, patients will need to be referred to an ophthalmologist to be seen, but it's not an emergent referral to them. Right, moving on to preorbital and orbital cellulitis. So many of these conditions I'm going to talk about, I'm going to go briefly through them, because many of them, we see them very commonly. We're mostly well accustomed to managing these patients, but a few tips and tricks or points, important points I'd like to make for the common presentations in the clinic or the emergency department. So for periorbital cellulitis, it's an infection surrounding the skin of the eye. It's caused by Staph aureus or strep pyogens, and you'd see preorbital redness and swelling without ocular or systemic manifestations. So meaning you don't have a fever. These kids usually don't have a fever, and they don't have visual changes or painful extraocular movements when they move their eye. They're treated with oral antibiotics, amoxiclav, cephalexin, or clindamycin. So for orbital cellulitis, it's obviously an infection that goes beyond the orbit to the back of the eye, and it's usually spread from a sinus or a dental infection. Common organisms are strep anginosus, Staph aureus, strep pyogens, strep pneumo, or H. influenza. And for those patients, you'd see preorbital redness and swelling, kind of similar to the preseptal or periorbital cellulitis, but you also have painful extraocular movement, proptosis, visual disturbance. As well as in 2/3 of the patients, they would have a fever. Now, if you're suspecting an orbital cellulitis or an orbital abscess in some advanced cases, you obviously need to do an emergent orbital CT, because it's a vision-threatening infection. And these are treated with IV antibiotics, such as cloxacillin or Vanco plus ceftriaxone plus minus flagyl. So some complications, if you don't treat them in a timely fashion, would be vision loss, intracranial abscess, subperiosteal abscess, meningitis, or cavernous sinus vein thrombosis. Of course, these patients would also need to have the ophthalmologist involved after it's been diagnosed. Right. Stye, chalazion, and blepharitis. So a stye would be an acute infection of an oil gland or hair follicle. The patient will present with a small painful lump either under the eyelid, either lower or upper, and it would be on the edge of the eyelid. These are usually caused by Staph aureus, and because they're a minor infection, most of the time warm compressions are enough. Now, some references would also add a potential benefit of antibiotic drops, but usually just warm compressions are enough. Chalazion is blockage of the meibomian gland. They're less painful than a stye, but may also become infected, and they're treated with warm compressions as well. Blepharitis is basically inflammation of the eyelid margin, and they're usually caused by bacterial colonization. You can see crusting on the base of the eyelids, of the eyelashes, and they're also treated with warm compressions and also daily washing. All right, moving on to the lacrimal system. So this is more for the newborns, neonates. Uh, Newborns may present with dactyria stenosis. This is something we commonly see in newborns, and it's basically obstruction of the nasolacrimal duct systems or system, or sometimes just narrowing of it. And it presents normally, or not normally, it presents in 6% of the newborns. It's not completely unheard of. And a patient would present with unilateral tearing and discharge. So this happens from incomplete development of the lacrimal duct. And they are treated with just massaging the edge of the eye, the nasolacrimal duct and canal, and with warm compressions. Now, these are self-resolving typically. 90% will resolve by 1 year of age. And if they don't resolve by then, it'll be reasonable to refer them to the ophthalmologist. No, for more advanced condition of the same pathology is dactyria cystocele. When the lacrimal duct is so narrow, or the obstruction is slightly lower than with dactyrial stenosis, you'd have collection of the tears in a duct, and that would cause swelling and bluish swelling of the nasolacrimal duct. And these patients would need urgent referral to the ophthalmologist. Finally, for the lacrimal system, dactyrial cystitis. So it's basically partial obstruction with infection of the lacrimal system, and patients, as you can see in the picture, will present with redness, swelling, and tenderness of the lacrimal sac. These are associated with purulent discharge. So you want to take a swab and send for culture and start them on IV antibiotics. And of course, admission and emergency ophthalmology consultation. Right, conjunctivitis. I'll briefly go through childhood conjunctivitis, then we'll talk about neonatal conjunctivitis, which is more important and concerning for the preservation of the vision. So for childhood conjunctivitis, about 50 to 75% of the time, it's bacterial if it's an infection cause, and it might be caused by an infection or a non-infectious etiology. So one study looked at how to be able to differentiate between viral and bacterial infections, and they noted that in children who are older than 6 years, who present between April and November, and they don't have any watery discharge or any glued eyes in the morning, have a 92 probability of a negative bacterial culture. So these patients do not need antibiotics. Some common organisms for bacterial conjunctivitis are strep pneumo, Staph aureus, H. influenza, Moraxella catarrhalis, which are the most common. You can treat them with erythromycin or ciprofloxacin eye drops or ointment. Now, drops are slightly better because ointments will cause some blurriness of the vision and might be less tolerated. And the outcome is more or less the same whether you use drops or ointment. Of course, viral conjunctivitis are treated supportively, and allergic conjunctivitis are treated with antihistamines. Now, treatment of bacterial conjunctivitis is not necessary in many cases due to the self-limited nature of the disease. And antibiotics have been shown to induce earlier remission of some strains of bacterial conjunctivitis. There was a meta-analysis that showed that patients with purulent discharge or mildly severe red eye may have a very small benefit from the antibiotics. And they seem to be really more effective in patients with a confirmed positive culture result. So not all conjunctivitis needs antibiotics, even if it's bacterial. Now, the important conjunctivitis are the neonatal. So if a young child and a neonate presents with conjunctivitis, the pathology could be dependent on the age. It could be different depending on the age. Usually, if they present in the first 2 days of life, it's a chemical conjunctivitis. Children who present between day 2 and 5 of life, gonococcal conjunctivitis is a big concern. Between 5 and 14 days of life, chlamydia conjunctivitis, and finally, HSV conjunctivitis can present of course, at any age, but in the first 6 weeks is more, there are more risk for it in the first 6 weeks of life. So for gonococcal conjunctivitis, patient will present with very severe purulent discharge, and it's easy to have both eyes affected. If these patients do present to you, then they need to have a full septic workup, including an LP, because you're looking for any possible gonococcal systemic infection. And of course, you'd want to take an eye swab and send for culture of the discharge. It's treated with copious irrigation and IV ceftriaxone for 7 days. Now, cefotaxime for 7 days. Alternative, you may use ceftriaxone. A single dose of ceftriaxone has been mentioned as per the World Health Organization, but it's not the preferred method. As you know, in neonates, ceftriaxone might cause increased stasis of bilirubin excretion. So if a patient has neonatal jaundice, that might make it worse. So cefotaxime is preferable than ceftriaxone. Now, sorry. Topical antibiotics are alone not enough, and you would need IV antibiotics. And if you're already giving them IV antibiotics, then topical would be unnecessary. For chlamydia conjunctivitis, may be associated with chlamydia pneumonia in weeks to months later, usually 6 weeks to 8 weeks of life. Patients should have conjunctival and an NP swab for NAAT, and they're treated with oral erythromycin for 14 days or azithromycin. Now, as you recall, most of us would use azithromycin, and reason behind that is there's a slight increase of possibility of developing pyloric stenosis if you use erythromycin over azithromycin. So azithromycin is preferable, and it's a shorter duration. If you have a patient with chlamydia or gonorrheal infection, then they should be treated for both due to high co-infection rates. Right, so finally, HSV conjunctivitis. These patients present with clustering vesicle lesions with erythematous bases around the eye. Neonates will sometimes have skin, eye, and mouth involvement. If you recall the types of possible presentations of an HSV infection in a neonate, you'd either have skin, eye, and mouth, central nervous system, or disseminated. Usually, the HSV infection in neonates will present the first 21 days or so, first 3 weeks of life. But if you have one of these, then you'd need to do a full septic workup to look for any other possible infection sites with HSV. These patients would need admission for IV acyclovir for at least 14 days, and sometimes up to 21 days if it's involving the CNS. Right, so moving on to the anterior segment pathologies. A common presentation we see, I think that's one of the more common presentations for an eye trauma is corneal abrasion. Of course, diagnosing them would be with fluorescein eye drops. Then you can use the blue light to visualize the abrasion. They're treated with antibiotic ointment or drops. Do remember to not patch the eye. You can use a shield, but not patching, because patching might delay healing as it affects the epithelium of the eye, and might delay healing. And the referring to the ophthalmologist or indication to refer to ophthalmologist is if the pain is increasing after 1 or 2 days, if the abrasion is affecting the visual field, so right on the pupil, if they have really, really large abrasions, if it doesn't look like it's healing after 3 to 4 days, if you see a foreign body and you try to remove it and you're unsuccessful, or they have worsening vision after a few days of the trauma. Okay, so here's a patient that might present with a white dot on their eye, and this is because they might have bacterial infection or bacterial keratitis. Uh, Organisms are usually either cons, coagulase negative staph, or staph aureus. They have a foreign body sensation and pain. Bacterial keratitis are treated with topical antibiotics. Usually they're simple, they don't need any referral to ophthalmology, unless if they're complex and they become chronic, then you can give them an outpatient referral to the ophthalmologist. Keratitis could also be caused by HSV again. These patients present with unilateral pain, redness, and surrounding vesicles, just like in the neonate. And on fluorescein eye exam, you'd notice a dendritic pattern, which is pathognomonic for HSV infection. And they're treated with either topical antivirals, or sometimes you need to add a systemic oral antiviral if it's really bad, or even sometimes IV antiviral medication. Right, so sometimes a patient will present with eye redness. Now you want to be vigilant to pick this one up, because if you notice with this eye, the redness is more concentrated around the iris. So you see, it's like there's a ring of inflammation and redness around the iris. And this is slightly different from conjunctivitis, where it's more diffused. So if you see redness around the iris, you want to keep in mind if the patient has uveitis, iritis or uveitis. So this condition presents with painful red eye injection, photophobia, and they would have visual changes. Sometimes they have abnormal pupil shapes, and it is important to be able to recognize this condition because although not imminently urgent or vision threatening, more than 25% will have systemic manifestations or a systemic disease, specifically a rheumatological issue. So they need an ophthalmology referral as an outpatient. So these are some possible shapes the pupil might present with in somebody who has uveitis. So it's not completely circular, it's kind of abnormal borders. All right, so trauma. So patient might present with blood in the anterior chamber, that's called hyphema. It's almost always caused by trauma, rarely caused spontaneously from, for example, recent eye surgery. No, patients with sickle cell disease are a particular risk of hyphemia and its complication of rebleeding. And we graded based on the amount of blood in the anterior chamber. So the more blood it is, the higher the grade. If it's less than 1/3 of the anterior chamber, then it's grade 1. Between 1/3 and half, that's grade 2. More than half the anterior chamber, that's grade 3. And if it's occupying the full anterior chamber, then that's grade 4. And prognosis, of course, depends on how severe or which grade the hyphema is. So if you have a patient with hyphema, you'd want to elevate the head of the bed to about 30 to 45 degrees. You want to use an eye shield. You can apply cycloplegic eye drops like cyclopentolate or scopolamine, and topical anesthetics to help with the pain. You can use tetracaine, for example. Of course, only apply the eye drops if you're able to rule out a globe rupture or an open globe. Antiemetics as needed. You want to keep the patient, you want to avoid having the patient to vomit, because when they vomit, that it will increase the intraocular pressure. So antiemetics would be helpful for that. And of course, an emergency ophthalmology consult. Kids who have, or patients who have grade 1 or 2 high female might be discharged and followed up in the clinic daily. Patients who have grade 3 or above would need admission, as well as any patient who has elevated intraocular pressure, or they have sickle cell disease or a bleeding disorder. Because one of the major complications is rebleeding, which might occur after 2 to 7 days, especially in those who have sickle cell disease or trait. All right. So, a few possible causes of acute vision loss. It's a differential you want to go through in your head when somebody presents with acute vision loss. You want to divide them either if they're either when they're in pain, or if they have no pain. Those who have painful vision loss, you want to suspect really trauma, such as globe rupture, hyphema, corneal abrasion. Sometimes iritis, uveitis will present with painful vision loss, optic neuritis, endophthalmia as well. Painless vision loss could be caused by retinal detachment, vitreous detachment, or vitreous hemorrhage, retinal artery or vein occlusion. This is mostly in the older population. I've never seen it in a child. Lens dislocation, and usually the cause of painless vision loss is trauma, and that will most likely cause one of these conditions. So for the posterior segment of the eye, really the best way to be able to see what's going on in the back part of the eye is by doing an ultrasound. You'd want to use a linear probe, and remember to use the ocular settings on the machine, because there is this theoretical risk of thermal damage to the eye. It's never been documented, but it's a theoretical risk. So you'd want to use the ocular setting because it has a very low thermal index. So how would an eye look like on the ultrasound machine? So you see, this is the eyelid right here. This is the anterior chamber of the anterior segment. This is this is where the aqueous body lies. This is the lens. This is the back of the eye where the vitreous body lies. And of course, you have the retina here, and this is the optic nerve going into the eye. So this is mostly how you'd be able to, if you get a good clip or a good visualization of the eye, this is how you should see it. And of course, patients will move their eye. So this is how it should look like when you're uh, visualizing the eye. Again, this is the globe, the lens. You can see here for a quick millisecond. That's the lens, the optic nerve, and this is the retina right here, covering the back of the eye. So this is a normal eye exam or eye ultrasound. Retinal detachment, mostly caused by trauma, sometimes by congenital eye abnormalities or surgery, and these patients would present with painful vision loss. This is how it looks like on the ultrasound. So you'd see the retina kind of detaching from the back of the eye. You see here, it's not difficult to spot. So if you only have a limited experience with ultrasound, and you scan a few normal eyes to know what they look like, you can easily detect a retinal detachment. You see the retina there; it's kind of separating from the back of the eye. Obviously, if you see this, then the patient will need immediate ophthalmology for a consultation. Another condition that can present with painless eye loss is vitreous hemorrhage. Again, could be caused by trauma, most likely by trauma. Retinopathy of prematurity, sickle cell retinopathy, or retinoblastoma. So they also might present with nystagmus or strabismus, as well as vision loss. And on exam, you might see leukocoria. So because there's blood in the posterior segment, you can see the blood clot floating in the vitreous body or vitreous fluid. And it's called the washing machine sign because sometimes as the patient moving their eye kind of could float around, look like a washing machine. But yeah, it's not, again, not difficult to spot. This part of the eye, where the vitreous body is, you should see only black. It should be completely anechoic. So if you see a body here, it's either blood or sometimes a foreign body. Somebody presents with a foreign body trauma. You can also use the ultrasound to look at the back of the eye and see if there's a foreign body stuck within the vitreous body. Another condition where an ultrasound would be useful is in lens dislocation. It's mostly caused by trauma again, and they present with painless vision loss. If you do diagnose it, of course, patients will need immediate ophthalmology consultation. Other conditions that also might cause lens dislocation are patients who have Marfan syndrome, Ehlers-Danlos, or homocystinuria. They might present with spontaneous lens dislocation. And when you put a ultrasound on the eye, you can see there's something here in the back of the eye, and that looks like the lens. It should be right here. You can see it missing. It's not where it should be, and it's floated to the back of the eye because the patient will be obviously most likely lying on their back when you do the eye examination. So one thing I forgot to mention about when you do the eye exam is you want to use copious amount of gel when you apply before you apply the probe on the patient's eye, because you don't want to apply pressure with the probe on the eye, especially if somebody presents with an eye trauma or with eye pain or eye complaint. In younger patients, it's sometimes not they don't tolerate having gel applied directly on their eye, so you might want to use a Tegaderm. You can apply a Tegaderm and tell them if you want to if you can play with them and tell them you want to be a pirate, or you can pretend to be a pirate and put an eye patch on your eye, and then you put the gel on top of that to be able to see the back of the eye. Older kids, they usually tolerate having gel on their eyes quite well. All right, so here's another scenario where an eye ultrasound would be useful. A 2-year-old presents with new onset strabismus of the right eye. You do an examination, you see leukocoria. There's no trauma, just strabismus and leukocoria on your exam. You put the ultrasound probe on the kid's eye, and you see this. So this is obviously there's a mass in the back of the eye, and this would be retinoblastoma. So if you have a young infant, especially in the first 1 or 2 years of their life, and you notice leukocoria, easiest and quickest way to be able to see if they have retinoblastoma is with the bedside ultrasound. And of course, if you see this, patient will need immediate ophthalmology involvement. So this is a nice kind of pocket card from pocus101.com. You can, if you go to their website, you can keep this in your phone, and it will kind of remind you of what you're supposed to see when you do an ocular ultrasound, how to do it, and what are the common pathologies you might see when you do the ocular ultrasound. So I recommend anybody interested in point of care ultrasound to take a picture of this and keep it in their phone. And of course, practice using the ultrasound machine. All right, moving back away from the ultrasound. I'm going to talk about chemical burns of the eye. For children, household cleaning products are the most common cause of ocular burns. Of course, if you remember, for ingestion, alkali are more dangerous, and it's the same thing for exposure to the eye. Alkali is more dangerous than acidic chemicals. You'd want to immediately irrigate the eye and manage their pain. So to be able to irrigate, you want to put some tetracaine eye drops and rinse their eyes. So if I'm not sure how many clinics or urgent care clinics or emergencies, emergencies should have this Morgan lens. It's a lens where you put it inside the eye and you attach it to a saline bag and get it to continuously drip or infuse saline and irrigate the eye through the lens. You can use normal saline, Ringer's lactate, or water. Now, if you don't have the specific Morgan lens, you can MacGyver your way into irrigating the eye. You can use a nasal cannula and connect it to a saline bag. You put the nasal cannula just like in the picture and put it on the patient's nasal bridge and get it to continuously drain or drip to irrigate the kiddo's eye. Of course, before doing that, always remember to anesthetize the eye. Kids will not tolerate having water or saline dripping on their eye without anesthetizing the eye. So the procedure of irrigation you'd need to irrigate for at least 30 minutes. You'd want to measure the pH before and then irrigate for 30 minutes and then re-measure the pH. Your goal is to get the pH at around 6.8 to 7.4 at a neutral level. If you measure the pH after 30 minutes of irrigation and it's still abnormal, then you'd want to resume irrigation and recheck every 15 minutes. Once the pH is neutral, you can discontinue the irrigation, and half an hour after no irrigation, remeasure the pH and make sure that it stays neutral, doesn't go back to being too alkali or too chemical. For some young patients, you might need to sedate them if they're really young, 1, 2-year-old. Even if you anesthetize their eye, not going to be enough, so you might need to sedate them. After you neutralize the pH of the eye, the patient will need antibiotic ointment, and you'd want to contact the ophthalmologist for further instructions or follow-up for that patient. One unique chemical is the hydrofluoric acid, because these are highly corrosive inorganic acids, and they bind to calcium and magnesium to form insoluble salts. These patients will need irrigation of saline or Ringer's lactate plus 1% calcium gluconate to minimize the binding of the calcium and magnesium. And for those kids, you'd also want to do some blood work because sometimes they would present with serum hypocalcemia, hypomagnesemia, or hyperkalemia. All right, so moving on to ocular trauma. No, some of the previously mentioned conditions are caused by ocular trauma, but these are kind of more specific. So orbital blowout fracture. It's the most common orbital fracture in children above the age of 5. Common signs and symptoms are endophthalmosis, the eyeball kind of going inwards in the eye socket, in the orbital socket. They'll present with pain, sometimes diplopia, sometimes numbness of the ipsilateral cheek and upper lip. Now, the diplopia is going to be more prominent with vertical gaze if they try to look upwards, especially if there's orbital tissue herniation into the maxillary sinus, causing restriction of the inferior rectus muscle. So it'd be tugging on the inferior rectus muscle, like so, here, right there. And when the patient tries to gaze upward or look upward because of the herniation of the rectus muscle, they won't be able to. And you'd get a patient that might present like, they might look like this when if you ask them to look upwards. The left eye, for example, the unaffected eye is able to freely gaze upwards, but the affected eye will be limited in being able to do that. When we say orbital blowout fracture, we really mean the floor of the orbit, fracture of the floor of the orbit. There's also a fracture of the roof, the medial or lateral sides, but the blowout fracture is really the floor of the orbit. So the fractures are obviously diagnosed by a facial bone CT, and you might, the radiologist might see herniation of the orbital tissue into the maxillary sinus, as seen here. And if there's herniation or restriction of the rectus muscle, then operative repair is indicated. It's also indicated for large fracture or muscle entrapment or strabismus. Yeah, patient with strabismus. Right. One thing to also keep in mind when a patient presents with an orbital trauma is compartment syndrome, orbital compartment syndrome. Um, so what happens, this is usually caused by trauma, and it's what happens is due to the trauma, there's retrobulbar bleeding that causes increased pressure on the eye, on the back of the eye, and the eye will protrude forward, and that will increase significantly the intraocular pressure, and that's of course threatening to the eye's vision. So some of the signs and symptoms that might present are proptosis, subconjunctival hemorrhage, decrease or loss of vision, limited eye movement, afferent pupillary defect. So if you shine the light on their pupils, it's gonna be sluggish. And it's diagnosed with a tonometry, and you notice significant increase in the intraocular pressure. Now, this is an immediate life-threatening condition. Vision-threatening condition. You'd want to immediately relieve the pressure to preserve the eye and the vision of that eye. And it's done by doing a procedure called lateral canthotomy and inferior cantholysis. You can Google it, and there's a lot of clips on YouTube that shows you how to do it. It's a simple procedure, but it's not for the faint of heart. If you're not used to using scissors near the eye, then you just want to consult the ophthalmologist immediately to be able, so they can come and do it as soon as possible. Now, the best prognosis is if the blood supply is restored within 2 hours. So if the pressure is relieved within 2 hours, they have a very good prognosis in preserving their vision. Non-surgical possible treatment modalities is using IV mannitol or acetazolamide, or some will also recommend using steroids like methopred to possibly help with the inflammation. All right, so finally, globe rupture or an open globe. So this is obviously most likely obviously caused by trauma. You might see brown or black material on the sclera or cornea from a choroid plug, from leaking material from within the eye, and then causing a plug. You might see something like this. They might have a teardrop-shaped pupil. Most of the time, they'll have 360-degree hemorrhage around the iris. There's of course decreased intraocular pressure because the globe is open. Some of the vitreous fluid has escaped, and they'll have volume loss of the eye. Sometimes, if you're not sure, you might want to do further imaging like a CT or MRI to be able to diagnose it. So this is an abnormal shaped pupil because there's a perforation right there. This is what a 360 hemorrhage would look like surrounding the iris. And of course, for management wise, do not apply any pressure on the eye. You can just, if you're suspecting a globe rupture, you should only examine the eye with observation, no palpating the eye or applying any pressure at all. You'd want to elevate the head of the bed to 30 or 40 degrees, 45 degrees. Place an eye shield to further protect the eye from any further damage. Analgesia, systemic analgesia, antiemetics, again, because a vomiting patient it might cause them to lose more of the vitreous fluid. They need IV antibiotics to prevent endophthalmitis. You'd want to use either ceftazidime or ciprofloxacin plus vancomycin. And of course, they'll need an immediate ophthalmology consultation as soon as possible. So in summary, You'd want to promptly recognize any ocular emergencies, and that's crucial to prevent vision loss and or any long-term complications. Red flag symptoms a patient might present with, you'd want to kind of investigate more or be on the lookout for is acute vision loss, restricted eye movement, local chorea, severe pain, especially if it's out of proportion, and especially if, for example, if it's secondary to an eye trauma. You'd want to protect the eye with a shield, never with a patch if you need to protect the eye. Immediate ophthalmology consultation for a few conditions like ruptured globe, hyphema, retinal or vitreous detachment, obviously orbital compartment syndrome. Utilize the focus, especially for posterior segment pathologies. Just make sure they don't have an open globe. And finally, parental education. Eye goggles during playing sports. And if their child's eye was ever exposed to a chemical, they need to do immediate irrigation, starting from at home, even. Right. That's